This is the Darshan Talks podcast. Before this week's interview with Dr. Emanuel Fombu on COVID-19's impact on telemedicine, Darshan will introduce this episode with a recap for the week of Thursday, May 14th, 2020.
So this has been a bit of a slow week. People have been talking about COVID and people are starting to get restless. But I've done a bunch of different podcasts, and the big takeaway has been that COVID is affecting how we're going to do business. I can think of three very clear ways COVID's going to affect business. All of them are not necessarily game changers as much as COVID has accelerated the direction of where we're going. Number one, I think we're going to land up with more virtual working. And that means that your employees may not be sitting out of your office anymore. They may ask, no. They may demand that they sit out of their own houses, do their own work at their own time. So that it's the end of your traditional 9 to 5 because little Johnny still has to go to school and he comes back at 3 o'clock and the mother or the father taking care of them wants to take that time off, take care of little Johnny, get him settled in, and then go back to work. The second thing we're looking at is an acceleration into decentralized trials. I've had a bunch of different conversations, and the big takeaway has been that decentralized trials are here. The question is, will they stay? And I think that there's an argument to be made that based on the investment that are taking place, decentralized studies will start making more of a footprint. I would be surprised if the decentralized trials go as quickly as people are expecting, not because they don't mean as much, but because all the investments aren't completely there yet. Which means that it becomes a nice add-on, but I don't see it becoming a here to stay for the next year to 2 years at least. Stay tuned, reach out to me if you think that I'm wrong about this. I could be wrong, leave a comment. The other thing that I think will be here to stay is this idea of patient centricity. And patients have now started looking online, and we've always been looking online for information, but patients are now going to say, I want to be able to handle my life in the way that I want to handle it. And with that comes the concept of telehealth. With that comes the idea of how does one reach out and be understood by your clinicians, by your clinical trial staff in a way that meets them on their own terms. So those are my big three takeaways. Another sort of bonus takeaway is the fact that Zoom meetings, GoToMeetings, the other different formats out there on connecting virtually are likely here to stay. Companies already talking about reducing their office footprint. Companies already discussing what are better ways to engage. JP Morgan actually came out and said that they're going to reduce their footprint. So if all that is true, the big question is going to become, how do I look professional when I'm in my own house? How do I make sure that my walls are clean? How do I make sure that my outfit doesn't clash with a Zoom background? How do I make sure that I stand out and look professional? There have been instances where people walk away from their Zoom meeting without their pants on. And that's obviously problematic. So there can be a whole discussion on that as well. But I just thought that was an interesting tidbit that I've been following over the last couple of weeks. If you disagree with me, if you think that I missed out on where the next direction is for the life sciences, for healthcare, feel free to reach out to me and stay tuned.
This is the Darshan Talks podcast. Regulatory guy, irregular podcast with host Darshan Kulkarni. You can find the show on Twitter at Darshan Talks or the show's website at darshantalks.com.
Hey everyone, welcome again to another episode of Darshan Talks. As usual, we have one of the premier speakers in the area of health tech, in the area of health IT, in the area of health itself. He's been recently featured on Fox News New York, where he spoke about COVID-19. He has his own radio show on Heart 97, We have Dr. Emmanuel Fombu. How are you, Emmanuel?
I'm doing great, Deshaun. Thanks for having me.
Thank you for coming on. Emmanuel, would you like to introduce yourself, talk a little bit about what you're doing? Before we started talking, we had a very brief conversation about the type of work he's into, and I thought it's going to be a good setup for us to talk about some of the things we want to get into.
Sure. So, my career started in clinical medicine, and through working in pharma, worked at Bayer, Novartis, and recently Johnson & Johnson. And now I spend my time as a deal professional, doing a lot of mergers and acquisitions, of financing of companies, whether it's in the biopharma side or medtech side or digital health, and advising companies about what direction the industry is going in, and how best they could position their companies to be successful.
So that really speaks to, what you have is a front row seat to what's happening, and interestingly enough, we're going to talk about COVID because that seems to be on top of everyone's mind, and everyone's talking about how the world has ended, and it's the start of a new world. And you and I had this very brief discussion of when I started talking about how the world has ended, and you were like, no, we're talking about the start of a new world, and you raised some interesting points, and you want to talk a little bit about what you sort of hinted at.
Correct. So the COVID-19 pandemic has really literally hit a restart button on our lives, right? No one expected this. This literally came out of nowhere, and this has literally destroyed everyone's plan for 2020. Whatever the business strategy anyone had completely changed, right? The idea of telework is now the new norm, right? Students taking classes online is become the new norm, right?
Yeah.
Telemedicine has become the new norm. The idea of remote patient monitoring has become the new norm, and now vaccinations and infectious disease area has become a hot topic in healthcare, which was not literally the hottest topic. I remember in January being at JP Morgan conference in San Francisco with a lot of investors and a lot of companies, and the discussion was not around infectious diseases, right? It was more focused on rare disease, oncology, kind of areas of opportunity. But now, if you look at every major player in the industry, is literally scrambling to bring a solution, whether it's a cure or a vaccine for COVID-19. So the world is completely different. We're all quarantined in our homes, and basically is the point of something I called the new normal, right? And that new normal is what we all have to build together.
So that really raises the question of the new normal. Is this a new normal during this COVID-19 crisis, or do you see that carrying over after the crisis is over? Like, do you see investment dollars going into infectious diseases? I mean, we all know that, what was the last antibiotic that came out? It's been forever. And the reason is because it's a short period of time, someone gets better, and the drug's never used again until the next time you get it. And that's not great for stable revenues for a company. Do you see that changing?
Correct. I see in the short term, I see there'll be a lot of interest. I mean, right now I see like everyone and their godmother has a new product that works for COVID-19, right? So there's a lot of noise in the space right now. Certainly, I don't see new investors necessarily that interested in jumping in and taking that risk. But there's certainly a lot of products in the market. I think the big players are already in the space that were already traditional vaccine players. Like if you look at Sanofi, you look at BMS, Novartis, all these companies are already making moves for cures. So I hope that is something that hits the market within 12 to 18 months from now for a vaccine angle, right? But it's also the idea of until the vaccine gets here, what do we do? So until then, we have to actually, try to cure the disease and manage disease, right? And so you've heard every other kind of drug that supposedly cures COVID-19 infections, but that's up for grabs. So there's a lot of interest there. But I don't necessarily think it's a hot investment market because a lot of the drugs that people are talking about are generic drugs.
Correct. Hydroxychloroquine.
Right? So it's good. I mean, that research is being done in those areas, but I don't think it's a hot area for investors. The interesting piece of what is happening in the industry now is, if you look at hot areas for investments like gene therapy, oncology, rare disease, these patients that are supposed to be part of the studies are actually at higher risk of being infected, right, or dying from this particular infection. So they are staying away from hospitals. Non-essential or medical procedures, for example, are being stopped. I think recently, this week, I think in New York, they might open up some where people can have elective surgeries, for example. Mm-hmm. And so think about it. So if any ongoing clinical study was taking place in cancer patients, guess what? Those studies are probably on hold right now, right? Because you want to expose those patients going into a healthcare center, to take part in the trial. And so those things are being affected on a massive scale. And so this has literally changed the way we think about doing clinical research in the future. I don't think that mindset is going to change. I think it's a reboot on the way we all think. I think going to concerts, going to the airport will never be the same. And the great way I liken it to is like 9/11, right? Before 9/11, we could go through the airport. You didn't have to take off your shoes. You didn't have to get your back screened. You didn't have to, literally go through like X-ray, body searches to go through. But that became the norm, and we adapted to that. Going to the airports, for example, I see the current world and the post-COVID-19 world being exactly that, where temperature check-in before you board a plane, for example, could be the norm, right? Showing the fact that you have been vaccinated against COVID-19, or you have antibodies to COVID-19 for you to get into a restaurant or concert hall or nightclub or bar. And so I see that as a new norm of what will just become part of life.
But don't you see that as being something during COVID-19? Next year when it comes around, it'll be another version of COVID, or COVID-22, or whatever it is. I'm making up numbers here. But if that happens, aren't we always chasing what the new version will be? I mean, that's literally what vaccines look like for pneumonia, right? So every year they come up with a new version. So I guess the question I'm asking here is, if we're going to change the world to fit this new paradigm, how does that work when the paradigm itself is unstable, if you will?
Correct. Which is very interesting here. I mean, the discussion about pandemics has been something that a lot of public health officials have been talking about for a long time, right? So if you look at, there are multiple, cases of people like Bill Gates talking about this in a TED Talk several years ago, right? Yeah, President Obama talking about this several years ago. A lot of global public health officials have been talking about this. We've had SARS, we had MERS, right? We had H1N1. So the idea of having this kind of flu pandemics is nothing new. But having a new virus such as COVID-19 in a global world where people travel and the ability for this to spread, and the financial losses that businesses and countries have suffered, will permanently engrave our minds, and we'll not forget this, right? This is the first time in our generation where we've seen something this big that happens globally, right? Where you literally cannot escape to any place, right? Because everything is on standstill, right? Planes are flying empty. And so it's a complete different kind of mindset. And going forward, the next thing might not be COVID-22. It could be something else.
Right, exactly.
Up, right, but we know that this is real, and that something like this could happen. And so we will forever become more proactive about this as opposed to being reactive, because every business owner knows that if this actually happens again, we will not be able to withstand this.
Interesting. So you're seeing it more from a societal viewpoint, if you will, which is how is society going to adapt, whether it's the temperature checks and maybe business planning. I know, for example, I'm general counsel for one of the companies and for a startup. And one of the big things we reached out to the insurance provider and we asked them, do you guys cover this type of business stoppages as part of our insurance coverage program? And insurers are having a really hard time basically saying, no, we don't. And their argument is, we didn't cover COVID-19. And it's kind of hard because a lot of insurance policies come out and say things like, we'll cover SARS-like symptoms and SARS-like infections. So it's going to be interesting for the next few months and years. But I don't think too many insurance companies can absorb this type of loss. And if it was going to absorb this type of loss, they would have to do this in an unprecedented way. And everyone's insurance costs will go through the roof for it. So it's interesting you're talking about just at that societal level. And you sort of then zoom in on healthcare. You talk a little bit about how everyone's not moving, which means everyone's staying at home, which means we're talking about telework, we're talking about remote patient monitoring. What are you seeing in those spaces?
In those spaces, I'm seeing a couple of interesting things, right? And so one of the most interesting things is around a new kind of technology called like nanotechnology, and the company is called like Nano Vapor Biotech, where they actually have product that you could actually spray on the surface that actually kills viruses and bacteria for a long period of time, right? Which is very different from our traditional way of disinfecting things, where you use just an alcohol-based hydrogen peroxide based killing. So you see new technologies come out of that kind of arena. If you look at the idea of telemedicine in general, teledoc. Teledoc before when they went IPO, their stock initially went up, and then it was on this downward trend. And you could hear everyone talking about, telemedicine is sitting in the past. People have tried telemedicine and it didn't work. But now with COVID-19, the demand for telemedicine services have skyrocketed. For telework, if you look at Zoom, if you look at all these other companies that are providing this telework kind of services, Microsoft Teams, right? Even Facebook is getting into the idea of telework, right? You could use our platform, our live stream platform on Facebook to do this, right? So everyone is getting to this thing. If you look at things like Instagram, they're hosting conferences, right? Especially in our industry. If you look at, it was typical at this particular point. I'll be probably on a plane somewhere flying to some conference, to give a talk, or medical conferences happening. But guess what? All that is on standstill now. Right. And now the only way we can communicate now is through online kind of technologies, right? Conferences have gone virtual. Everything has gone virtual. Something that we didn't think will actually happen from an experience point of view, but we are doing those things now. So that is picking up. The idea of virtual clinical trials is also picking up now. Where for a long time I've made that argument, and many other people have made that argument, that when you do a clinical trial, for example, patients live far from the clinical trial site. Sometimes transportation was a major issue, but yet, this is the way we do things. So the burden was still on the patient. But today, going forward, everyone that designs a clinical trial will take that into account. That yes, it's possible to remotely monitor patients. And with that being said, there's a new industry booming around companies that could have devices that you could actually measure vital signs at home, right? So those kind of companies now are popping up because if you do telemedicine, whether it's through Teledoc or any other platform, what happens is you still need to collect some kind of vital signs, right? So the doctor is looking at you, they still have to take some kind of objective measure, blood pressure, heart rate, ECGs. So they need those kind of data sets. And so there's a lot of, there's a big boom and boost of investments coming into those kind of companies that make hardware that could actually collect these devices, collect these vitals right at home.
So that's kind of interesting to me. And you brought up two different points that I want to dig into a little bit further. One is you talked about the rise of telemedicine, and the second is you talked about just virtual clinical trials. And we'll talk about both, but let's start with the telemedicine. Obviously, there are areas where telemedicine makes a lot of sense, but I speak to a lot of friends of mine who are in healthcare, who are PAs or MDs, and their big thing is, I don't get all the information I need. It's very impersonal. It takes longer than you would think. People think that it's a shorter period of time, but now the daughter walks into the room, the dog comes up, I don't get the attention I need to be able to make the decision, move on. I can't see all the patient's walk. I can't, even if I do see the patient's walk, I can't fully evaluate what that looks like. So all of those bits and pieces, I'm wondering if telemedicine is going to have a role, but it doesn't actually replace the physician-patient relationship. Does it become or augment what mid-level practitioners use, as opposed to replace what physicians do? What's your take on that?
Correct. I think a lot of telemedicine work could be done by nurses and physician assistants, right? Even doctors as well. If you look at from multiple aspects, so this argument, prior to COVID-19 was one of the reasons why telemedicine was stalled. That's one. Two, the reimbursement rate for televisits were lower than an in-person visit, right? So clinicians were not incentivized to do a televisit as opposed to an in-person visit. If you look at, but today it's completely different, right? CMS will reimburse and other private insurance companies will actually reimburse the same fee for face-to-face visits as they do for telehealth. So the incentive is there to drive adoption from the provider side. The next piece of this is, I can't remember the last time anyone said, I cannot wait to go to a doctor's office and sit there for hours and hours to see a doctor or a nurse, right? I mean, the typical day, if you have an appointment to see a clinician, literally you have to have the day off work or take the entire day off work. With telemedicine, you literally can just book a time and have that conversation, even from an annual physical. So I think there'll be a volume gain here where a lot of people will actually check in with doctors and have a more preventive approaches to healthcare, as opposed to going to the emergency room when things are late. So I think people will become more proactive with in healthcare, and healthcare providers become more accessible that you could talk to. So that's another advantage of that particular system, and I think the incentives are aligned with that particular element of things. Yes, I do agree that a face-to-face interaction, like any other interaction, it's fantastic, right? I would love, to be with you right now in the same room having this conversation,
right,
but we still have an effective conversation
sure,
through your podcast, right? And we have, a lot of listeners right now that, will learn and contribute more to society and to our environment and continue this dialogue virtually, and we do not meet face-to-face, right? When we meet face-to-face, we could have a much deeper conversation and build a much deeper connection. But it doesn't prevent us from actually communicating and moving forward with what we need to get done. So I will argue for the fact that, we need to adapt to this kind of way of doing things and move forward with it.
So I guess I'm not disagreeing with you. I'm agreeing with you. What I'm wondering is, putting on that fortune teller's hat, do you see a future where both become necessary? I think we both agree that that's probably going to be true. That both forms, both live and in person, and this electronic telework, telepharmacy kind of thing becomes a real thing. My question is, what is the niche that telepharmacy occupies? Or are you saying it might encroach quite significantly on the current practice of medicine? I use the word encroach,
yes,
not to say replace, but yeah.
Correct. So I see. So which one is cheaper? And that to begin with, right? If we say, okay, what's going to happen in the future, and we are looking at what will happen in the post COVID-19 world, first of all, payers realize that it's way cheaper to do televisits than it is actually showing up in a doctor's office or showing into the emergency room, right? Definitely cheaper. And so I see a lot of investments, and I see a lot of interest in pushing for remote patient monitoring. Just today, actually, I just saw an article this morning about United Healthcare being interested in possibly acquiring the remote patient monitoring company, a telehealth company, Able2, right? And the deal is looking at about $500 million.
Quick question for you, though. Quick question for you.
Companies making moves in this space.
Quick question for you. You said something which I'm trying to understand. A few minutes ago, we talked about how the reimbursement was not the same, and therefore the doctors are were hesitant to use telehealth, teleoptions, if you will. And then you just said that it's cheaper for insurers. Could you explain how both would be simultaneously true?
Correct. So previously, the reimbursement was not the same, right? But today, the reimbursement is the same for face-to-face visits.
Yep.
And so, they're the same for face-to-face visits as same as if you do telemedicine. So that's incentives for clinicians to participate.
Sure.
And then I said that it's cheaper for insurers to actually focus on telemonitoring and remote patient monitoring as opposed to patients going into the emergency room. If you show up in the emergency room, yeah, correct. If you show up in the emergency, that's where people go. People don't when people get sick, for like people have a cough or they have fever or something, they go straight to the emergency room, right? Which is very expensive.
Right.
That's why you see. That's why in the last several years you've seen urgent care centers popping up around the place because they're cheaper than actually showing up in the emergency room. When you show up at the urgent care center, emergency room is more expensive for the payer than if they actually pay for a face-to-face visit, just like you pay a primary care doctor when you go into the office. When people get sick, you don't walk into the primary care doctor's office usually, right? You have to make an appointment to go, but if you have a fever today, you can't get an appointment with your primary care doctor, you go to the emergency room. Majority of people today don't have a primary care doctor that they actually go see on a regular basis. right? So that's why you see companies like ZocDoc, for example, with a platform where you could go and book appointments on a short-term basis to see a doctor. But otherwise, the emergency rooms are getting flooded with people. And that's why if you look at the whole reimbursement codes about 30-day readmissions and trying to keep people away from the emergency room, there's been a big movement towards that, right? The Affordable Care Act was specifically designed around that, to keep people away from that. And so you see with this movement and people adapting to this and clinicians being able to use this, patients being comfortable with using technologies for work, for school, talking to your doctors. So that mindset is already changed, right? And and innovation usually happens when we have our backs against the world, against the wall, when we don't have no choice but to adapt, right? And that's where we are today. We have no choice but to communicate, through the phone, FaceTime, doing concerts on Instagram or on TV and watching other concerts on TV. That's the norm, right? Watching sports on TV is the norm. The discussions today about, like the Yankees opening up the baseball season or the NBA opening up, and people are going to, there'll be no fans in the audience, right? Ever watching TV. So that is becoming the norm. And so people get used to this kind of idea, and the idea of virtual communication will not be that strange after all. And don't forget, the social distancing society we live in today is going to continue way into 2021, right? And so the idea of us putting masks today looks strange, but by the end of the summer or it goes to December, will become the norm because we'll be wearing masks, right? Today, you can't go to a grocery store in New York without putting on a mask. It's required. So everyone puts on a mask. 6 feet distance between people is the norm. Going to restaurants and being able to sit far apart from each other will be the norm. JetBlue just announced yesterday that starting in May, like May 21st, every passenger must put on a face mask, right? So you see a new world where we adapt into because we are forced to.
Right. So I mean, there's so many questions that come out of this for me. The first thing that really strikes at me is that obviously COVID in this case is spread by droplets. So masks get us partially there, but aren't you still spreading it with your hands? So from a clinical perspective, what's your take on that? So that's a short question, but I'm just curious about it.
Yeah, so that's a very interesting piece of it. That first it was put on gloves and wash your hands, but we know that this droplet lives in the air, it's airborne, and people get infected, right? And there are many studies that have shown that it actually goes beyond 6 feet.
Right.
So the best idea here, yeah, correct. And so I think we're doing the best we can to just mitigate risk, but I don't think it's the perfect solution to what happens. I don't see a society where we walk around being distant from each other. I think probably the side effects of that is probably worse than actually being close to each other, right? I think physical contact between humans is actually very important. So I actually like the term, social distancing as opposed to physical distancing, right? I mean, we will, like as humans, we need to be around each other in the general sense of things, but keeping that space, but yet finding ways to communicate with each other is actually the best way to go.
So I'm gonna pivot a little bit now, and I'm gonna talk a little bit about virtual clinical trials. By the way, just so you know, this conversation is going way longer than we expected, so thank you for your patience of staying on. But you talked about the idea of virtual clinical studies, and obviously we've been talking about virtual clinical trials for a long time. Pfizer's done one a long time ago, and we've had some learnings from it. It sort of peaks and ebbs and flows. I've done some interviews with sites, and they talk about similar things. My big takeaway, let's sort of take a step back from virtual and start with the first piece, which is, as you mentioned, a lot of studies have stopped because we needed to get, no one wants to expose your oncology patients to the hospital environment where you might get sick. How are you going to start that again? Do you think they're going to start virtually and go from there, or do you see them sort of starting in a scenario where you come back and we sort of catch you up? Will the protocols have to change? How do you see this working in the immediate term after COVID?
Correct. I see a lot of protocol amendments happening, right, to take away some of those in-person visits to virtual visits, or have it amended in such a way where we actually send like a healthcare provider, nurse to the patient, as opposed to the patient coming in to see the clinician. So I see a lot of protocol amendments happening. Imagine doing a study today looking at quality of life measures, right? I've designed clinical studies in the past looking at quality of life. Multiple studies have quality of life as an endpoint, and which is what is most important to payers, right?
Yep.
So quality of life measurements today would look at, if you look at devices, look at activity. How many steps did you walk last week? Were you active? Were you able to mow the lawn? Were you able to go grocery shopping? And all those things, right? In a sick patient population where we're telling them to stay home and get groceries delivered to you, don't put yourself at risk if you're a high-risk patient. And we know that patients with comorbid conditions are actually at higher risk of mortality, right? If you look at, patients with diabetes, COPD, asthma, heart failure, they have a higher mortality rate than the average patient population, right, that has COVID. And so those patients, you're asking them to stay home. So imagine you had a study ongoing right now, and those patients are not allowed to move. That entire endpoint is done. You can't study that, right? So the way of defining what you meant as quality of life is completely different prior to COVID-19 and what is happening today, because patients are restricted. So that study cannot go on. So you have to completely amend those or put those studies on hold.
And you just restart them at that point.
And what happens to those? Yeah, correct. And so what happens to those patients do they take their drug at a regular time interval? And if they do, what exactly are you measuring? Right. So some of these studies will have to be scrapped. Some of these studies have to be redone all over and redesigned to be launched. So the impact of this to industry is massive.
So I agree with you 100%. I think the impact's massive. I think the cost, once this is all figured out, is going to be catastrophic. This which is really interesting, and I'm sort of going off on an offshoot here, but they're already talking about how the stock market's coming back, and it's only 16% off from its all-time highs, which is really and the all-time highs were like a month and a half ago. But while all that is happening, I can't even understand if we have so much uncertainty. So many studies that were stopped, so many plans, and I'm just talking health, and there are obviously multiple other industries that are affected similarly. That's not counting industries that have just plain stopped, like the restaurant industry. But I wonder how this is all going to play out in the stock market in the long term. As an investment banker, do you have any thoughts about that?
Yes, in the long term, everything is going to work out. If you look at the current stock market situation, right, the stock prices are down, but it's not necessarily because of the economic problem, right? So if you look at 2008, for example, we had a financial crisis, but that was because the banking infrastructure in general was not strong enough, right? We had bad lending practices, so that's why the system was down. Today we have a situation in which a pandemic is actually disrupting businesses. The core of those businesses are strong, but customers are not allowed to actually engage with the businesses. Like you mentioned, the restaurant business, for example. If you look at the oil and gas business, or even Uber businesses, all these businesses, groceries, retail, all the shops are completely locked down, right? So everyone is at home. So look at retail in general. People are not buying new clothes to go out. Makeup, barbers, everyone is down, right? So, but when it opens, I think there'll be a big rush in demand for people to get back into taking care of themselves and getting back into society. So that is another interesting piece of it. So I think will definitely rebound. This is a global thing. And so it's not focused on one particular industry. But what would change in general is that for the first time, healthcare is going to be in the backbone of every single industry, regardless of where you are, right? So before, talking about health and being proactive about healthcare was a luxury kind of thing that businesses were not necessarily interested in, or was not in their core business. But just like terrorism was, that put fear in every single industry going forward, and safety around that. I think healthcare and making sure we are safe and being proactive about healthcare will be at the center of every single business, whether you're, regardless of what business you're in. Healthcare will be at the forefront of this.
So, yeah. I mean, I agree. It's interesting. All I've heard is a doom and gloom version of no one's considered all these things. We're gonna see 2-3 quarters of impact, of financial impact. And I really like the take you had, which is that may be true, but you're going to see a major boom in work once we come back, because the world's going to basically restart, which I think is so understated. So I appreciate you saying that, and it's that glimmer of hope that I haven't heard personally in months, well, weeks. It just feels like months.
Correct. And you being Dr. You're a regulatory guy, right?
Yeah.
And so one of the biggest challenges, being in this industry for a long time, especially healthcare, was that healthcare is a heavily regulated industry, right? Getting things like telemedicine kind of work done in the past has been a massive challenge because of the regulations around it. Doctors could not see patients across state lines in most instances, and so there was a big challenge there on how you do that. Getting drugs quickly approved has been a challenge in most cases. But in today's COVID-19 world, we've realized that some of those regulations have been downgraded a little bit, right, to spur innovation and to spur adoption to these things, which could be a catch-22, right? And so I'm happy to see that some of these regulations have been down, but I'm sure you probably have a different take on that.
I do have a little bit of a different take on it. But you and I before we started this talk, we talked about, you raised this exact issue. And I totally understand where you're coming from, because I think there's something awesome about the world going, we'll stand up and we'll take this disease head on. My concern in doing this at in a quote unquote normalized world is I can't even trust my Fitbit to tell me the number of steps I took. I literally every single day get a different number of steps from my Google phone and my Fitbit. If that's true, how do I trust some kind of remote monitoring system to tell me what my blood pressure and my pulse is? In the end, my experience is that not only are the systems in most cases flawed, because they're often created this with a lot of medical devices work off of the way Google and Apple and all of them work, which is start with an imperfect version and keep creating slight modifications over and over and over again until you get a robust, great system. Healthcare works very differently from that, which is you need to get it right the first time. And that fundamental difference in philosophy is hugely problematic. So in the same way, I suddenly don't believe that the tools work as well as they should. You need a fundamental change in philosophy to make that happen. You take the second piece of that and you talk about physicians working across interstate lines. Now, as a concept, I love that. That sounds great. Except you land up having different bugs. You land up having different standards of care when you cross interstate lines. Someone working in Arizona and someone working in New York almost definitely has very different ways they treat patients. Not because the patients are different, but because the standard of care is different. So they're exposing themselves and the patients to a variant form of standard of care. And as a concept, is that the worst thing in the world? Maybe, maybe not. But you're gonna get different results because of it. Now, how do you know which results are better? I don't know. You take the. Go ahead. You want to comment?
Yeah, sure. And I agree with you. I think we should have some regulations in place, right, or some kind of guideline.
Sure.
In place that I think every company needs to hit some kind of bare minimum kind of element, right? But let's address in that particular area of clinicians being able to see patients across lines, state lines. I think the same issue will apply even within the same state, right? So look at New York, for example, where in Manhattan you have significantly more people that tested positive for COVID-19. Yet the mortality rate in the Bronx, which is literally across the river, the Hudson River, right, has twice the mortality rate of people dying from COVID-19. So the access to care, even within the same state, is completely different, right?
Without a doubt.
If you're in Manhattan and then you have access to New York Presbyterian, or you could go down to Mount Sinai, main hospitals, or NYU. yeah, you have great service, but go down to the Bronx. They don't even have testing available to those areas, right? In those poor areas. So there's the same thing within cities, and the doctors are practicing the same thing within state lines. So is it possible if a doctor in Wisconsin, for example,
Sure.
that was in an environment where they're not flooded with patients with COVID-19 and not overwhelmed, could interact with a patient out in the Bronx, right? If you look at the cost-benefit analysis of it, is it not worth giving it that shot?
So I'm not necessarily opposed to the shot. I guess what I'm wondering is, for example, I'm making this up, right? But patient comes in and says, I have a cough. Today it is, I have to go to my local doctor, and my local doctor will write a script for Keflex for me. I don't know if that's right, but yeah. And you're taking it 4 times a day. On the other hand, if I go to Arizona, they go, you know what? I'm not sure. We don't have the same bugs. We're gonna go with a slightly different, I don't know, some other drug. And the question that I ask at that point is, if and the way I see this working is it's not gonna be just a random doctor, right? What'll probably land up happening is you'll come up with what's the word I'm looking for? Some kind of phone centers or something like that, where you've got 10, 15, 20 doctors sitting and they just keep taking phone calls. And now you've got these 10 doctors in Texas dictating care across the entire country for areas they may or may not know. And that difference may be fundamentally problematic. Now you say, okay, maybe ID is a weird situation. We shouldn't talk about infectious diseases in that specific way. Maybe we need something different for that. Okay, fair enough. Then let's take something like heart failure, and the treatment for heart failure in, I would guess, rural Wisconsin is very different from the treatment of heart failure in New York City. And the question I start wondering is, does it make sense for, say, 15, 20 doctors sitting in New York City, because that's where your hub is, telling a farmer that, you know what, you shouldn't wake up at 5 a.m, you can't take the stress? Is there a different form of stress that we simply don't understand because we're not in the same place? So again, this, to me, it's a question of, and I recognize your point, which is, don't we already have variants of standard of care? And I think your answer is yes, we do have variants, but at least we're working with the same basic sets of knowledge, if you will. I think you risk the chance of health disparities, the risk of greater health disparities by causing unregulated telehealth. But obviously, I think your point is right, and maybe there are better ways to organize this than we've considered. Are we on the same page, or I don't know if we're on the same page?
No, but the point you're bringing up is interesting. So if you look at, if you're a physician in the United States, every physician took the same exam.
Yeah.
Right? Everyone took the same exam. When it's a drug available, to treat a particular disease,
yeah,
the guidelines mandate that every single patient in the U.S. should be treated on this particular therapy. So that's why you go to the FDA and you get approval for the drug in a given patient population. So it should be standard. It is true that how people, the affordability question actually influences how people, get access to care. But I think it should be standard. I think a patient with heart failure in Arizona and a patient in New York or wherever you are, if you fit the same criteria of what was studied in a clinical trial and the drug was approved for, you should be able to get access to the best therapy that's available, right? And so if I'm a physician in New York and I decide to move to Florida, a patient with heart failure is a patient with heart failure. I do understand that certain details about that patient might change, right? Certain diet restrictions based on the local thing that people eat will be different nationally, globally. But let's not forget that for the last several years, you look at radiology as a practice. Right. A lot of MRIs and X-rays have been read by doctors outside of the United States at nighttime. When radiologists in the U.S. are in bed, those images are being sent across country lines. Yeah. And other physicians outside of the country that never met you actually reading this and sending reports back.
But I think those doctors still have to be licensed in the U.S., if I remember correctly.
What you said?
Those doctors still have to be licensed in the U.S. So if that's true,
correct.
Would you still say that Dr. Smith prescribing in, I don't know, in New York should also have a license in Arizona, or are you saying that that's not necessary?
I think there should be a simple way to get a doctor's license in every state, right? I mean, there are states today that would show reciprocity, right? Where you have a license in one state and then you're also able to practice in another state. Like California is not one of them, or you look at Texas, for example, right? And so, what is the difference if I took a national exam and I'm certified as a physician, and then I have to go down to California to apply for a new license and then wait months and months and months? I mean, it's a fee-based kind of model, right? So I'm not saying that we should have people that are unqualified to practice medicine in places. I'm saying these are people that are already licensed in a state that could help other people where they're overburdened. If you look at New York City right now, there's a lot of intake from nurses and doctors from outside the state, right, to come into New York to help people in the city. Because the healthcare workers are overwhelmed, right? Just recently, like suicide rates among clinicians and nurses that are taking care of these patients is going up. So there's a big impact to mental health kind of things. And so how do we, as a country, decrease the burden and pressure on healthcare workers? And I think doing something like this, where you could open up, the ability of clinicians to practice across state lines, actually helps improve healthcare.
We could keep talking about this for so long. This is such an interesting topic, but I think we're past the 40-minute limit. What I'd love to be able to continue this conversation if you're open to it, and love to have you back again. But I think we should stop here and organize another meeting if that's okay with you.
That's definitely okay. It was great having a good conversation with you. Great discussions.
This was a great discussion. Thank you. Again, thank you for coming on, Dr. Emmanuel Fombu. And Dr. Fombu, where can they reach you if they want to reach out to you?
You can reach me on my website, emmanuelfombu.com, or drmanny.md.com.
Sounds great. And thank you again for coming on, and we're excited to have you back soon. Take care.
This is the Darshan Talks podcast, regulatory guy, irregular podcast with host Darshan Kulkarni. You can find the show on Twitter at Darshan Talks, or the show's website at darshantalks.com.